Hey, are you scared that you're going to be told you can't have surgery because of your weight? If so, keep listening.
Nope. But I'm real interested in what you're going to say next.
Ever since I published my ebook, Jenny Needs a New Knee, but she's too fat to get one, people have come to me and said, hey, this is really useful, but I don't need a new knee. I need a different kind of surgery, and I'm also being denied it because of my BMI. What can I do? So I want to start by saying, I've heard you. I hear what you're saying. It's not enough to just have one for knee replacements. There are so many different surgeries being denied on the basis of BMI, which is not only completely unethical, but also not founded in any evidence.
No evidence? Really? Because from where I'm sitting, there's plenty of evidence. Here's a study, but there are plenty more that show the complications in knee arthroplasty in morbidly obese patients. And the statistics, they don't lie. If you go through them, you can see that overall complication rates go from 9% to 23%. You can see that early complications after revisions go from 10% to 23%. Deep prosthetic joint infection goes up by an order of magnitude of 2.38. And revisions for any cause, well, they're 30% more likely. So from where I'm sitting and from the stats that I'm looking at, there is plenty of evidence.
Fat people do better after surgery in the long term. Whilst there might be increased risk of things like infection, which are easily manageable, fat people have a lower mortality rate, lower rate of blood transfusion, lower rate of cardiac complications and kidney complications. Check out the comment below for more resources.
Okay, I found the study that Asher is talking about. And what's absolutely laughable about it is what she calls long-term is 6 months. The study lasted 6 months, and they assessed the patients during their recovery and how they were doing at 6 months. And most of the studies that I've looked at show that real complications start after a year. In fact, after 3 years, that's when the real complications start. And if you're morbidly obese, your likelihood of having those type of complications range from 30 to 140%. The study also showed that obese people had lots of complications in the beginning. This is something that Asher would like to gloss over, thinking that infections are not a big deal. But the data shows that obese patients had way longer surgeries and had infections and a whole bunch of other things that, yes, they could manage, but made their first few months of recovery very difficult. When Asher says that obese patients do better in the long term, what they really mean is that the obese patient had a grueling surgery that lasted way longer than the surgeries of normal weight people. They had infections and a painful recovery, but were able to stabilize around 6 months. And at 6 months, their recovery was quite similar to those that were of an average weight or an average healthy weight. But the study did not keep going. And that's where the real problems start to happen. So all of the replacements and revisions and other problems, they happen around 3 years. And this study didn't capture that. So the real science says doing these surgeries on obese people, especially morbidly obese people, have lots of risks at the beginning. The surgery is longer, the surgery is harder, there are more infections, there are more revisions in the beginning. Then around 6 months, we can expect some sort of stabilization where pain is relieved and all patients are feeling better, especially obese patients. They're feeling a lot better. But then the real problems start to happen with revisions, more pain, more infections, etc. And the risks of that are 30 to 140%. I have more to say on this study, but Asher has more to say, so I'll let them continue.
I'm a doctor.
Not a doctor. You lost your license.
who spent the last 20 years telling patients to lose weight prior to surgery, and I was wrong. Here's why. The research shows 0 improvements in complications, 0 difference in recovery time, 0 difference in long-term success. The long-term outcomes are exactly the same, irrespective of BMI. The supposed additional risks are grossly over-exaggerated.
So why don't we take a little deeper look at this study that Asher is talking about and see if there's any validity in it. Now, first of all, I already told you this study only spanned 6 months. So their long term is after all of the surgical recovery is over. It's not truly long term. It's not like years out. It just means, did you do okay and recover from your surgery? And in this case, the obese patients and the patients of a healthy weight, yes, their stats were similar. But let's look at some of the holes in this study and show why this is so not an accurate representation. Okay, so first of all, this study only concentrated on 3 things: repeat surgery, death, and knee pain and function. But what the study didn't really talk about was the data on complications such as surgical site infections, deep surgical site infections, pulmonary embolism, anemia, urinary tract infections, readmissions, etc. There's a lot of other statistics there that they did not present. Like I said, the functional follow-up, it stopped at 6 months. So at 6 months, the morbidly obese people and the obese people said, yep, my pain is fine. I have improvement in movement. I'm feeling good. But how long did that last for? We don't know. 6 months is the last time they did a follow-up. Also, for these studies, there is a selection of healthy obese. I do think that our society does not understand what obese truly is. Like, we think that people that are deep into class 3 obesity are obese class 1. And that's not true. Most of the people that you think are just average are actually obese class 1 or obese class 2. And in my opinion, these are probably the types of people that were in the study. They didn't have Tess Holliday-sized people in this study. They didn't have Hannah-sized people in the study. And if you remember, Hannah was the one talking about needing back surgery, and her BMI is way off the charts. In fact, I'd like to use this time to do a little bit of education on BMI, because I think a lot of people might know what their BMI is, but don't really have a grasp of the rest of the scale and what the other BMIs actually look like. So here's a body mass index table. And if I go to my height at 5'4", I can see that my normal range goes from 110 to 140. I'm sitting right now at 135, so I am in it, but you can see that I'm at the top of my range. And when I was 156 pounds, look at that, I was overweight. But you see, it doesn't take much. 174. I've been there. I've been there when I had babies. That's considered obese. Now, this is all grouped in class 1 and class 2, but class 2 changes at 35 on the BMI scale, and that would be 204 pounds. Well, you know what? I know a lot of people who are my height and about 204 pounds. That is still obese class 2, okay? That is not that big in terms of our North American society, but that's what it is. And if I was obese class 3, morbidly obese, I'd be 232 pounds. That is still not as big as what we view society as morbidly obese. If I was 232 pounds, I bet you a lot of people would just call me chunky and not morbidly obese. But yeah, that's really what it is. And if I go all the way to the end of this scale, in order for me to get a BMI of 50, I have to be just under 300 pounds, 291 pounds. And that would be a BMI of 50, which is considered super obese. Well, how obese is North America? Like, I'm kind of thinking that we don't need to have 3 classes of obesity. We probably need to have like 7, because we have a society that is way off the deep end, way past 50. We have a lot of people in our society that are that big, and we are treating them like they have a BMI of 40. And if you go down this line and you find your height, you can see, wow, you know what? That is big, but it's way smaller than I thought it was. You can also look at images if that helps you. If you look at images that show body fat percentage, anytime you see 30 or higher, that's considered obese. So if you look at images of people like this, starting here, we're hitting obesity at 30%. And you're probably looking at these figures and go, no way, that can't be what it is. But really, this is obese class 1, this is obese class 2, and this is obese class 3, and this is deeper into obese class 3. So what I'm saying is the people that got surgeries that were morbidly obese probably looked like that, okay? Not like a Tess Holiday, not like a Hannah Talks Bodies, not even like FatDoctor UK. They look like this. And that is part of the statistical bias. So ignoring Asher's study and doing a deeper dive on other studies, I found the following results. That the order of magnitude on having any infection if you're obese is 1.9, so over 90% higher. The order of magnitude on getting a deep infection is 2.38. Revisions for any reason go up by 30%. Early complications go from 10% to 23%. And those that have a BMI of 50 or higher have significantly higher risks. Now, it also needs to be said that only 2% of the sample size was considered super obese, which is a BMI of 50 or over. And remember, I just showed you what those BMIs look like. So you can imagine that there's a lot of people out there that have BMIs of 55, 60, 65, and 50 is considered super serious. So in my opinion, a simple 6-month paper does not outweigh the dozens and dozens of other studies that showed doubled infection odds, higher risks of serious complications, and 8-fold complications in super obese patients. Denying that the extra risks exist isn't evidence-based or care-based at all. It's wishful thinking.
So if there's no benefit to losing weight prior to surgery, and fat patients do just as well after surgery, why are we denying them the treatment that they need? Why are we forcing them to live with sickness, pain, and disability? Why are we making them wait years for their surgery and sometimes never even giving them the surgery in the first place? We're literally rationing healthcare based on bias and prejudice rather than evidence, and that is not okay.
I've just given you lots of evidence as to why. The study that Asher is using shows that obese people have far more complications during their surgery and during their recovery, okay, than people that have a healthy BMI. Those are the facts. They have far more complications, and some of them are quite serious that Asher wants to gloss over and think that they're not important. Then, at 6 months, things tend to stabilize. I mean, think about it. The surgeons are trying to do their best in the environment that they have. And their achievement is they got all their patients to stabilize, their pain is down, their movement is better. They did a good job at 6 months. However, things change. Real complications start after a year, and there is a 30 to 140% chance of complications in obese people in the long run. Not to mention that the study that you're pulling your data from had very, very few people in the obese class 3, which you and most of your followers are, and also had a selection bias to pick the healthiest of the healthy obese. I don't think that Asher and any of their patients, can I say that if they're not a doctor? I guess their clients, are in that healthy obese kind of category. And I'm saying healthy obese for probably class 1, maybe class 2. And if it is class 3, it's right on that line. It's right on that line. It's not people like Tess Holliday, okay? It's not really, really obese people that they have in these studies. They have people that are a little obese in these studies. So, Asher, if you're trying to convince surgeons to give surgery to obese patients that will take significantly longer, hours longer, than it would on a normal weight patient, have them suffer through infections and revisions, only to get them to a stable point at 6 months where they can say, yay, I'm the same as everyone else. For now, only to have a serious, over 100% chance of complications in the long run. That is why. The science doesn't lie. That is why.
So you're well enough for weight loss surgery, but too sick for a knee replacement. That doesn't really make sense.
It makes perfect sense. Knee surgery is life-altering surgery. Weight loss surgery is life-saving surgery. It makes perfect sense.
Did you know that the mortality rate from weight loss surgery is at least 15 times the mortality rate from knee replacement surgery?
No, it isn't. The mortality risk on bariatric surgery versus knee surgery is 30 to 59% lower.
The infection rate is 7 times higher in bariatric surgery than it is in knee replacement surgery.
Nope, that's not right either. The risk of infection on knee surgery is 6 to 7%, whereas the risk for infection on bariatric surgery is 0.4 to 1%.
In fact, the risks of bariatric surgery far outweigh the risks of knee replacement surgery.
Again, not true. If we look at the data like all-cause mortality, surgical site infection, deep prosthetic joint infection, cardiac problems, and other things, bariatric surgery seems to be safer on all fronts. The only statistic that I found that bariatric surgery was riskier than knee surgery was on early reoperation, and the difference was a range on knee surgery of 0.7 to 1.4, whereas on bariatric surgery it was 1.24. And that is a small difference. Every other statistic shows bariatric surgery as being safer. So then I was like pulling my hair out thinking, where the hell is Asher getting these numbers from? It doesn't make sense. I gotta find out. So I kept searching and I eventually found that they must be getting their numbers from a very, very old study. The study was about obese bariatric patients in 1997. If we haven't forgotten, the year is 2025. And there's been a lot of advancements in medicine. And the way that they did bariatric surgery back in 1997 is far different than the way that they do bariatric surgery now. So all of those numbers, yeah, they were true. More than 25 years ago, they were true. But they ain't true now. And this is a gross misrepresentation of a study. We should be looking at data from current studies, not studies that are nearly 30 years old that were done with medical technology that we do not use anymore. We should not be looking at studies from nearly 30 years ago to prove ourselves, okay? Those studies were based on surgeries done in a manner that we no longer use.
And get this, studies have repeatedly shown that bariatric surgery prior to a knee replacement actually worsens your outcomes. You had that right. It doubles your chance of pretty much every single complication, at the very least.
Okay, this one, she has a little bit of fact in there, but still not enough for me to say that what she's saying is true. The data shows that, yes, there is a higher risk for revision due to infection if you have bariatric surgery before knee surgery. However, Studies have also shown that this can be mitigated by waiting at least 6 months and preferably a year between the bariatric surgery and the knee surgery. That has shown a remarkable improvement. All of the statistics that I found showed that it is advantageous to have bariatric surgery first, because overall they seem to have less complications, 14% in comparison to 36%. They seem to have less infections, 2.2% in comparison to 4.6%. There are some other things that they're slightly higher. The superficial wound infection, 4.2 versus 3.9, but is that really significant? But their risk of venous thromboembolism is down by 25%. Their chance of a 90-day stroke is down by 42%. Like I said, the only thing that I found that was higher was this revision for infection, which is 1.1 to 4.7, which is higher than those who did not have bariatric surgery before their knee replacement. And any revisions, 1.6 to 1.1. As we can see by the numbers, the risks of complications pretty much go down if you have bariatric surgery before knee replacement surgery. There are a couple places where, yes, it is more risky, but overall, if you look at things like perioperative complications, joint infection, 90-day venous thromboembolism, 90-day stroke, all of these things go down. If you have bariatric surgery first, these risks in knee replacement surgery go way down. Now, there are a couple places where it does go up, but when it goes up, it's really, really small. I'm talking about like 1.1% versus 1.6%, or having a slightly longer stay in the hospital than someone else. Now, an interesting statistic is that if you do the knee surgery before the bariatric surgery, there is a significant risk. And we see that it's 7% of having a major complication versus 1.9 if it's reversed. And then the other thing that I had mentioned at the beginning is that they had discovered that timing makes a big difference. So we can mitigate the risks by waiting. They say if you wait at least 6 months and preferably 12 months in between, the overall complications go from 20% to 5% if you just wait a little bit longer in between the surgeries. And the other statistic that's missing is that people that have bariatric surgery first and start losing weight, 30% of the time, they cancel the knee replacement surgery because they no longer need it. The weight loss got rid of the problem. So if we look at why doctors recommend weight loss surgery before having knee replacement surgery, even though there are some increased risks, well, the overall risks are much lower. Their chance of VTE is down. Their chance of stroke is down. Their chance of deep infection is down. They have a shorter or similar hospital stay. And like I said, most patients lose enough weight that they don't need to have the knee replacement at all. Yes, there are some risks of more infection, but I need to circle back to this. When Asher was talking about knee surgery at the beginning, they glossed over infections and things like that because you can manage them.
Whilst there might be increased risk of things like infection, which are easily manageable.
Well, the risk of those infections was significantly higher than the risks of these infections, yet they are saying how much more risky it is and is willing to gloss over the infections for the surgery that they want and pay a lot of attention to the risks in the surgery that they don't want, even though the risks of weight loss surgery are very, very low. I have friends that are YouTube creators that have had weight loss surgery, and they would be more than willing to tell you that their weight loss surgery was worth it. Asher just wants to scare people, and this isn't right. So, no, having bariatric surgery before having knee replacement surgery is not super dangerous, okay? It does not increase your risks tenfold. What Asher is saying is not based on current science.
Folks, the math isn't mathing. And I'm curious, how long are we supposed to pretend this makes sense? When are we going to admit that this is just a ploy to make money?
Says the person selling books and courses. Who's trying to make money here? Asher certainly likes to cherry pick their data. Yeah, there is a little bit of truth in what they're saying, but you have to put together the whole picture to see that it's a lot of BS. The scary numbers of bariatric surgery are from 1997. Okay, and think about it back then, how they would probably open up your whole abdomen to do the bariatric surgery instead of using these telescopic micro incisions the way that they can do it now. Okay, so think about that. Those scary numbers are from 1997. The data doesn't lie. There are a lot of risks having any surgery if you are obese, but bariatric surgery is life-saving surgery. And if you lose the weight, there is a very good probability that a lot of your other health problems will also go away. So my question is, who is spreading information to educate the public? And who is spreading information to scare the public and make money off of them in the process? My name is Lydia, and this is the Body Honesty Project. And if you like this video, please subscribe.